A lung biopsy can be performed through the VATS method. This procedure removes a small portion of lung tissue for pathological examination. It is often performed when other diagnostic tests are inconclusive. Lung volume reduction surgery is also done via the VATS procedure for patients with chronic pulmonary emphysema. This procedure involves resection of portions of the lung. Usually the bronchovascular portion is removed because air is trapped in emphysemic lung tissue. Like many cancers, lung cancer spreads through the lymphatic system. The scalene nodes are the site most often biopsied to determine lung cancer metastasis. Typically, a scalene node biopsy is done along with a bronchoscopy. If the nodes are positive, they will look at treatment options because the cancer has already spread. If the nodes come back negative, they will proceed with a thoracotomy or a thoracoscopy to remove the cancerous lung lesion. A thoracotomy is an open surgery of the thoracic cavity. Thoraco means chest cavity, and otomy means incision into. The surgeon incises the skin, and the subcutaneous tissue and muscle layers are divided, usually in the fifth intercostal space. He or she will use his or her finger to protect the lungs while the incision is extended with the bovie. Laps will be used to protect the wound edges from bruising before the rib spreader is placed. A wedge resection is a surgical procedure during which the surgeon removes a small wedge-shaped portion of the lung containing the cancerous cells along with healthy tissue that surround the area. A segmental resection is when a portion of the lung larger than a wedge is removed, but not the entire lobe. A lobectomy is the removal of the lobe of the lung to prevent the spread of metastatic cancer or to treat a benign tumor. A pneumonectomy is the removal of the entire lung, and it is done to debulk malignant tumors, slow spread of cancer, treat extensive abscess, or treat broncholectasis. Broncholectasis is the chronic dilation of the bronchi caused by infection, pulmonary obstruction, or TB, tuberculosis. During the pneumonectomy, the surgeon will try to preserve certain nerves, such as the vagus, left recurrent laryngeal, and the phrenic nerves. Remember, the instruments that are used to cut across the bronchus are considered contaminated. A wedge resection, segmental resection, lobectomy, and pneumonectomy can all be done by VATS or an open thoracotomy. Thoracic outlet syndrome is compression of subclavian vessels and brachial plexus in the space between your collarbone and your first rib, the thoracic outlet. This can cause pain in your shoulder and neck and numbness in your fingers. Surgical treatment is the removal of all or a portion of the first rib. Decortation of the lung is a surgical removal of the fibrin layer of the lung to facilitate lung expansion, usually accessed through the incision in the fifth intercostal space. Disease causes the formation of exudate in the pleural space, causing the parietal pleura to adhere to the chest wall. Treatment involves removal of a portion of the parietal pleura with the goal being complete expansion of the patient's lungs. Lung transplantation is performed to remove diseased, poorly functioning lung and replace with lung from an organ donor. The donor can be living or a cadaver. Single lung transplants are indicated for patients with restrictive lung disease, emphysema, pulmonary hypertension, and other non-infectious end-stage pulmonary diseases. Patient position for a single lung transplant is lateral because it gives easiest access. Double lung transplants are indicated for patients with cystic fibrosis or chronic infection and end-stage pulmonary failure. Supine is the position used for a double lung transplant. In single lung transplant, the surgeon will make 3 anastomoses: bronchus to bronchus, pulmonary artery to pulmonary artery, and the recipient pulmonary vein to the donor arterial cuff. Bilateral transplant may require cardiopulmonary bypass, but bypass can be avoided by using the bilateral sequencing technique. The bilateral sequencing technique means removing the most diseased lung first, hoping that the healthier lung is capable of maintaining adequate oxygenation so the patient does not need to be put on the bypass machine. Negative pressure in the thoracic cavity is lost when the chest wall and pleura are opened or punctured. For the lungs to expand, negative pressure must be restored. This is achieved with a closed chest drainage system, commonly called a pleuravac. This system removes blood, fluid, and air from the thoracic cavity. The chest tube system will be aseptically placed on the back table before it is used. Chest tubes are sutured to the chest wall with a heavy non-absorbable suture and dressed with petroleum gauze, fluffs, and flat gauze. A sterile petroleum gauze is kept with the patient at all times in case the chest tube is dislodged. This gauze would be immediately placed over the hole to prevent air from entering the thorax and deflating the lung. It is also important to keep the drainage system below the level of the patient's chest. Other helpful hints are that the chest tube should not be clamped during patient transport unless the chest drainage system becomes disrupted during patient movement, and then only if there is no air leak. The chest tube should only be clamped with a physician's order.